Good morning, everybody. Thank you very much for inviting me, the organizers and the Nishant. Radiological evidence of tuberculosis or radiological appearance of tuberculosis, traditionally classified as primary TB, secondary or post-primary TB, miliary TB, and extra-primary pulmonary TB. So radiographical features usually depend on the type of infection, that is whether it's a primary or post-primary, age of the patient, and then the stage of infection and the location, whether it's a pulmonary or extra-pulmonary. As you are aware, it's a lung is the most common site, and it's also depend on the whether it's a primary infection or post-primary. The lung changes depend on that type of infection, and the location of infection within the lung also varies with the stage of infection and the age of the patient. So, in the primary infection can be anywhere within the lung in children, but whereas it has a more common in the upper and lower zones in the adults. The post-primary infection have a strong predilection for the upper zones, and the miliary is that is a widespread infection throughout the lung. So initial infection can be located anywhere, and it is non-specific, and most of the time it is too small to be detected. Then we call it a normal chest section. But areas of consolidation and the bronchopneumonia can develop into later appearance. But so remember, normal chest X-ray does not exclude TB. So most common finding in the children are, it's a, as you can see in the arrows, it's a lymphadenopathy. That is usually it is on the right side, right lymphadenopathy extending along the paratracheal region. And it's seen in about 90% of cases in children, but only in 10 to 30% of adult patients in the primary infection. And the second picture shows that is resolving lymphadenopathy after the treatment. Then sometimes these nodes can be so large and they might compress the airways and the bronchi and the trachea and giving symptoms. Especially you might see the subsegmental consolidation, which we call this as a atelectatic bands or atelectate. Then patchy consolidation is one of the common findings, especially in children. They present as we call bronchopneumonia, or they can develop into consolidation. As you can see here, this is a patchy consolidation in the small nodular-like pattern that is called bronchopneumonia, and this is the lobar consolidation in the right middle lobe. It's the same patient's appearance of CT. You can see the solid soft tissue density area with the air bronchogram. The air lucency is what we call is a non-obstructed branching pattern of bronchi. So that is called air bronchogram. Then these nodes may be too large. As I mentioned earlier, it can compress the trachea and even bronchi. That's arrow is it is obstructing the upper lobe bronchus, and it can extend even up there. And they have characteristic pattern. They usually have central lucent area that is due to necrosis and the peripheral solid areas. And this is the typical pattern of TB lymphadenopathy. That is, you get a central necrosis area with the enhancing ring pattern around in the peripheral area. So that is a classic pattern of lymphadenopathy. And this is the PET-CT with another patient. Actually, there's a limited role in the PET-CT in the TB, but when you want to find out whether it's active TB or active infection or a residual effect, you can use the PET-CT, where you can see the active nodes as high density area, that is consolidation area. This is the CT where node is there and the consolidated area. Then these most of the primary infections become localized and they develop into small granuloma or small nodular pattern, and what we call is a tuberculoma. Then eventually they calcify. So then we call it as a gonfocus. So if you look at this area, you can see the small nodules, 1 to 2 millimeter size, small nodules here. And this is another patient with gross calcification, gross changes with multiple small areas of calcification in the, that is called focus of tuberculoma calcification. And it is common to get calcification in the lymph nodes after the TB. So it is, you can find it about 35% of patients. If you see the gone focus with the calcification in lymph nodes, they call it a Ranke's complex. If you look at here, you can see a small nodule here and the here, right? That is about 2 to 3 millimeter size, a small granulomas with the calcification in the lymph nodes. So that's the main feature is here, it's a calcification. Right? Pleural effusion, usually in the primary infections, it is rare, and it is usually seen in adults about 40% of patients. Children, it is only about 5 to 10% in the primary infections. But here, ultrasound play a role. When they are detecting a pleural effusion, ultrasound can detect very early rather than the X-ray. So usually, it about 40 to 50 ml effusion can be detected in ultrasound, but in whereas we need about 200 ml to see it is in the chest X-ray. The cavitation is uncommon in primary TB, but you can find in some patients. So this is a patient with cavity in the left upper lobe, and it is seen only in 10 to 30% of patients. So then that is the appearance of the primary tuberculosis or radiographic appearance of primary TB. So the post-primary, that is known as either reactivation TB or secondary tuberculosis. So majority of cases develop in the lung, and they are common in the posterior segments of upper lobes and the superior segment of lower lobes. So the typical appearance is you will see the small patchy areas of bronchopneumonia or consolidation with linear bands. That is a typical appearance, patchy consolidation and the linear bands, and sometimes you might see the nodular pattern. Then with more advanced disease, you might see the more fibrotic bands or linear bands all over the chest. Then later you can see the pleural thickening. So these arrows are showing the pleural thickening with upper lobe consolidated like appearance, that is due to little bit of fibrosis and the pleural thickening. Then more advanced case with fibrosis, you can see that this is the left hilum, it is in the normal position. This is the right hilum, which is elevated, and you can see the linear band and the small cystic areas with thickened pleura, that is due to fibrosis. So the right upper lobe fibrosis secondary to TB. So more advanced case with more fibrosis in the both lung. You can see the again linear bands, patchy shadowing like appearance, and more advanced fibrosis. And this is a patient with almost complete fibrosis of right lung. You can see only little bit of normal lung tissue. This is the left lung. There are also some changes. Mediastinum is shifted to the opposite side. So lung volume is reduced. So there's a gross fibrosis from the secondary TB. And the cavitation is a common finding in the secondary primary TB. Usually you can see up to 45% of cases. And the vast majority, it is developed in the posterior segment of the upper lobe. So that's the same patient showing the cavity. And this is how you see it in the CT, right? So you can see the cavity here, and there are small areas of consolidation, a small nodular pattern. So that is actually cavitation with reactivation TB. And if you see the air fluid level or fluid level within the cavity, then you have to suspect any communication with the airway, or it may be secondary infection, or it may be fistula formation with the bronchial tree. So then the endobronchial spread, usually these secondary infections spread along the bronchial tree with a small nodular like 2 or 5 millimeter size, and they give a tree in bud appearance. So that is a famous name. I will discuss it later. And sometimes you might see the hilar node enlargement in about 1/3 of cases. Right? So that is what tree in bud appearance. So if you look at here, these bronchial trees are filled with the small nodules, giving the this appearance. So that is due to enterobronchial spread, but it is not limited to the TB. Any enterobronchial type of infection can give rise to this appearance. So this picture shows it better. So this is how you see it, and this comparison with the picture. That is enterobronchial TB. So the tuberculoma is rare in secondary TB, only account for about 5% in comparison to the primary tuberculosis. But it has been reported lobar consolidation, tuberculoma, and the miliary TB also in secondary TB, but they are rare. They are not the more common form like primary TB. So consolidation and the tuberculoma are rare in secondary TB. So these are uncommon case. Right, you can see the bilateral upper lobe consolidation and the shape patient CT showing the consolidation on the both sides. Then miliary TBs, it is uncommon, but it represent hematogenous dissemination. This is in the uncontrolled TB infection, but we are seeing it mainly in the chest X-ray. But you have to remember that it is all over the body. It is disseminated. And miliary, we call it is when these nodules are less than 3 millimeter. When it is usually 1 to 3 millimeter only, we call it is miliary, but they are uniform in size, evenly distributed, and the treatment is usually once it is successful, it will does not produce any effect on the lung. So that is the appearance. You can see the millet seed-like. That's why it's called miliary. Multiple small widespread nodules involved in the both lung fields in the all zones. And another patient, you can see the beta in this area because patient is having little bit of pulmonary edema also. So that's why you can see it clearly. And this is how you see it in the CT. You can see the multiple small nodules spread along the fissures and the perilymphatic areas, and as well as within the alveoli. Then isolated tracheal infection is rare, but sometimes it can produce soft tissue masses, narrowing, and thickening of trachea and bronchi. And this is a patient with infection in the carina. You can see the right carina here. Left carina is narrowed and thickened with the irregular margins. Pleural involvement we discussed earlier also. So that is another feature in the secondary TB. And it can be complicated by either empyema formation or pleural thickening. That is how you see the small pleural thickening here, and with a small pleural collection, that is very early pleural diffusion. And this is the large diffusion, which you can see the enhancing area, 2 arrows are showing, that is empyema formation. And this is pleural calcification, late sequelae of pleural effusion. You can see that this high density area along the pleura, and then Visha shape area in the lung. And here also you can see the pleural calcification. And this is a patient with chronic pleural effusion with calcification. This arrow shows there's a cutaneous fistula formation, that empyema is extending through the skin. And this is another patient with chronic empyema with calcification. This is the gross calcification of pleura with the empyema, old empyema. Right. So the complication of secondary pulmonary TBs are the aspergilloma formation and the pseudoaneurysms, and the empyema we already discussed, and the fibrothorax, that is the gross fibrosis of the pleura, and the bronchopleural fistula, that's also we have already seen. So that is the patient with cavity, and inside you can see the intracavitary body. That is a solid rounded opacity. So that is what the aspergilloma formation of fungal infection. And here you can see the thickened septae and the multiple small cystic areas involved in the mid and lower zone. That is bronchiectasis. This is how you will see it in the CT. So multiple dilated bronchi with thickened walls, and the sum of these bronchi are filled with fluid. So that's the same patient's coronal sections. Then this is the fistula, aneurysm formation. You can see the pulmonary artery, and at the same time there's some contrast leaking outside, and that is the pulmonary artery aneurysm, or we call Rasmussen aneurysm. And this is the angiogram showing active leaking of contrast. Then a few words about extrapulmonary TB. So diagnosis is often difficult, and the positive chest radiograph will helpful in the findings. And the radiographic features of the extrapulmonary TB mimic many others disease. So that is a challenge. So you have to be careful before diagnosing whether it's a TB, extrapulmonary TB, or some other infective focus or any other disease, because it can mimic so many, especially pyogenic infection and the other inflammatory disease. And you have to have a high level of suspicious in the highly risk population. And the positive culture and the histological diagnosis are more important in confirming diagnosis. So lymphadenopathy is the commonest form of extrapulmonary tuberculosis, and this is the CT scan of a patient's neck showing multiple enlarged lymph nodes with some necrotic areas. So that is, it's account for about 15% of extrapulmonary tuberculosis. And they have described 4 patterns of extrapulmonary appearance in the lymph nodes. So either they may be just enlarged with peripheral enhancement in the CT, or it may be large attenuated mass with peripheral enhancement, or it may be just a single large mass due to matted lymph node without enhancement, or there will be a lymph node with peripheral thin wall enhancement but preserved at way. So that's a patient with axillary tuberculosis. You can see the lymph node, enlarged lymph node with the central necrotic areas. Then central nervous TB, tuberculous leptomeningitis is the commonest form, and it is most commonly manifest as subacute or chronic meningitis. And it is difficult to distinguish acute TB infections with the other CNS infection. What you will see is there's a thickening of meninges and the exudate is collecting there. You can see the base of skull area. There's an enhancing exudate. And this one, you can see the meningeal enhancement after contrast. And it's another patient. This is the fourth ventricle is obstructed. You can't see the fourth ventricle. And exudate is there, enhancing meninges, and the exudate is there, then it causing hydrocephalus. And they can also present as infarctions, right? It's unusual site of infarction can be present in the TB due to a vasculitis. And the commonest typical pattern is this tuberculoma formation, where you can see the peripheral enhancing area with the central lucent area. But this pattern you can see in the toxoplasmosis and other infective features. So that's why I mentioned it is important to differentiate it, because it can mimic other disease, but this tuberculoma like this appearance is non-specific for the TB. Then even this tuberculoma can go into very large lesions. You can see the multiple varying size lesion with a very large lesion here. Sometimes they may be present as mass lesion. So then in the spine, you can see the enhancing meninges, and sometimes they might give the transverse myelitis-like picture. And the important one is this tuberculous spondylodiscitis. You can see this spine with a prevertebral mass here. It's an abscess formation. And look at here, you can see that these spaces are fairly preserved. So where you can differentiate it from the pyogenic. Several vertebrae involved, large mass, and the fairly preservation of this material. So it's in the TB and the pyogenic comparison. It's common in all thoracolumbar area and TB, or the thoracic area, and the pyogenic is lumbar, and the level frequently multiple. And in the pyogenic, it is usually in the 1, and the disc is preserved in the pyogenic, but it's variable in the disc, usually preserved in TB, but it is early affected in the pyogenic infections. Then you can get the TB in other organs like kidneys, right? They might present as a mass lesion or exudate collected in the pelvic system, or bladder lesions as a thickening of bladder. And bowel, again, thickening of bowel or mass lesion. And they can present as ascites, with a thickening of mesentery and peritoneum. And the joints, that is septic arthritis, again fluid collection, especially thick fluid collections. And this joint, even osteomyelitis can be affected. Right. So remember, this is at the start I told we are traditionally classified it as a post-primary and the primary, post-primary, miliary, and the extra pulmonary. But the recent DNA studies, that is genotyping of the mycobacteria isolated from the patients, shows that does not affect like that. It is depend on the patient's immunity. Because of that, you can get both the post-primary and the primary picture in the combination in the TB. Right, thank you.